Michelle Warner. Yes, you can do the woo-woo for her, yes. Who will share how the Massachusetts Public Health Department has utilized a racial equity lens in their implementation of the CDC's Exhale framework. Exhale is a set of 6 strategies developed by the CDC and the Prevention's National Asthma Control Program that contribute to better asthma control. The network is a proud partner and a CDC grantee. And please note, we have a number of resources available online for those of you who are online, and also in the back of the room over there when you first came in. Our speaker, Michelle Warner, is the director of the Asthma Prevention and Control Program at the Massachusetts Department of Public Health. She received a master's degree in public health from Tufts University and discovered her passion for public health 17 years ago when she began her career supporting community health centers across Massachusetts. She is a passionate advocate for addressing racial inequities, and eliminating the social, cultural, and structural barriers that exist in communities. Please welcome Michelle.
Do I have a little clicker? Oh, you have it. The green. Perfect. Thank you so much. This feels like, okay. Hi, thank you so much for having me here today. We were so excited to find out that, do you want me to go to the next? There we go. We were so excited to find out that the USA Asthma Summit was going to be hosted in Boston this year. So welcome to everyone who has traveled here from out of state. Well, on the one that's up here today, I really want to acknowledge the other members of the asthma team here at the Department of Public Health, their role in this work, especially Maya Dotton, who's here today from our team, and of course, all of our many partners. There's folks from Boston Public Health Commission, Health Resources in Action, Public Health Institute of Western Mass, Revitalize CDC. We have a lot of school nurse partners here today, so it's just so great to see everybody here, and we couldn't do this work without them. So today I'm going to speak a bit about how our asthma program here in Massachusetts is implementing the CDC's Exhale strategies through a racial equity lens. There we go. And so for folks who aren't familiar, the Exhale strategies are the CDC National Asthma Program's comprehensive set of strategies for addressing asthma that, as grantees of the CDC program, we are charged with implementing in our state. So as you'll see here, the E stands for Education on Asthma Self-Management. The X is Extinguish Smoking and Exposure to Secondhand Smoke. The H is home visits for trigger reduction and asthma self-management education. The A is achievement of guidelines-based medical management. The L is linkages and coordination of care across settings. And the E2, we call it, is the environmental policies or best practices to reduce asthma triggers from indoor, outdoor, or occupational exposures. So as I mentioned, our asthma program is part of the state Massachusetts Department of Public Health. And so I just want to recognize how fortunate we are here in this state that we really do have the support all the way up to Governor Healy's office to do this racial equity work. I know that that may not be the case in all states. And so you'll hear later on that some of this work really started at more of the program level. So hopefully, even for those of you that don't yet have that support at your higher level in your states, that you'll be able to take something back from what I'm speaking about today. So here at DPH, though, we really intentionally center our public health work on health and racial equity. We've recently updated our vision and mission statements to name, as you'll see here, really prioritizing racial equity and acknowledging structural racism. And so our asthma program here in Massachusetts sits in the Bureau of Community Health and Prevention, or BCHAP. And so our racial equity journey, as we call it, goes back almost 10 years now. So I have been in this role as the asthma director for just over 4.5 years, but with BCHAP since 2015. So I really do want to take a moment and just acknowledge and recognize and give credit to the folks that were on the asthma team before us for their vision and commitment to this racial equity work, and for really diving into it so many years ago, because they really created the blueprint for what has grown into what we now call our BCHAP racial equity movement. And so what did that look like? One of the earliest components of this work was the creation of what we call our why statement, which is exactly that, a statement of why we do this work and why we center racial equity. And so that's part of our explicit commitment to racial equity, really naming this focus and the specific inequities that we see. And so the asthma program developed a why statement that was eventually adapted into our BCHAP why statement that is actually still used today. And so this is an example of how we really try to use clear language and make an explicit commitment to racial equity when we talk about this work. The next component I have here is racial equity capacity building. And so again, years ago, our asthma staff, along with other folks in our bureau, began attending trainings that we call our 2-day racial equity training. So they're these it's really a deep dive into our personal identities, a look at our assumptions and biases and where they come from, as well as an exploration of the structural and systemic factors, historic and even current policies and practices like redlining or zoning laws that are really the foundation for some of these racial and health inequities that we see today, but also are still being perpetuated by some of the traditional public health programming that we were and many of us still are doing. So I will touch on that in a few minutes. But this 2-day racial equity training became a bureau-wide training, and it has actually now grown into a department-wide investment for our public health workforce. So it's now available for all DPH employees and staff, and everyone is very strongly encouraged to participate. Beyond this, our bureau, and in many of these instances now, the whole department offers affinity spaces, which are where folks that self-identify as a particular race or culture can gather, connect, share experiences, and unpack some of these topics together. We have racial equity town halls, lunch and learns, trainings for racial equity facilitation. So really lots of opportunity and investment in the staff across DPH to build our capacity to do this work. And then the third piece that I have here, and this ties back to the use of intentional language, is our use of what we call a leading with race and racism explicitly but not exclusively framework. So this is the concept that by focusing on race and racism, we're acknowledging that these systems that are failing our residents of color, who are most burdened by asthma, and especially poor asthma outcomes, are actually failing all residents. So by addressing these failures at an upstream, more systems level, our goal is not only to address the racial inequities we see, but also address some of the root causes of these inequities and improve the overall asthma burden for everyone in Massachusetts. So in our program, we talk a lot about the social determinants of health, or SDOH, and so these are the factors here in blue influencing people's access to money, power, and resources that really shape the conditions in which they are born, live, learn, play, worship, and work. So I really like this graphic in particular when talking about social determinants of health, because it acknowledges these other factors that influence health, like homophobia and sexism, but it really centers racism. And I'd be more explicit here to say that we're really talking about institutional and systemic racism and not that interpersonal racism. So really those structures and systems that are designed to benefit some populations over others. And so here we're acknowledging racism both as having an overarching impact across the social determinants of health, like when we think about housing, our education system, or food access, and is also an independent factor, right, going straight across to these health outcomes like asthma. And so in this vein, as I mentioned, our program has adopted a leading with race and racism explicitly but not exclusively approach, really centering the impact that racism has and continues to have on our Black and brown residents living with asthma, which has really shifted our thinking across how we do our asthma work. So on the previous slide, I mentioned the impact that structural racism has on asthma outcomes. And what we see here is what we refer to at DPH as the health tree. And this is not specific to asthma. Asthma is not even actually up there. But this is an exercise that we often do internally or with partners. And I have some amazing colleagues at the department that are part of the Root Cause Solutions Exchange that facilitate this exercise with local communities. But this is another way to look at social determinants of health and its root causes as the major drivers of health disparities that we see across these health outcomes. And so for time, I won't go through the whole thing, but just briefly at a high level. So the health outcomes are we see up in the leaves at the top, like here we see diabetes, obesity, and that's, asthma could be up there. Then the branches of the tree are the health behaviors that lead to those health outcomes, like smoking and stress. You could say we could put exercise in there. And then recognizing a person's ability to engage in health outcomes or health behaviors, recognizing a person's ability to engage in those healthy behaviors is largely influenced again by those social determinants of health, which you see here represented by the trunk of the tree. And then if you move down to the roots of the tree graphic, this is where we highlight some of those root causes creating these conditions or these barriers that can amplify the inequities that we see as we move back up to the leaves and the health outcomes. So when you're going through this exercise, you can really add the health outcomes that are specific to your work. So for example, with asthma, you could say asthma exacerbations or asthma-related hospitalizations, and then more specific to the populations and the communities you work in, you can work your way back down the graphic. So how are we in Massachusetts applying a racial equity lens to addressing asthma? So I've been talking about the racial inequities in asthma, or more specifically in asthma outcomes, and so I just wanted to show a little bit of data here. So what we see when we look at our state-level asthma data, and I know this is reflected in many other states as well, and nationally, the data show us that some populations experience a disproportionate burden of asthma outcomes. And so here we're seeing this difference in ED visits by race and ethnicity. And so we see the ED visits here from 2002 to 2021. You see the break in 2015 when we switched from the ICD-9 to the ICD-10 codes. And you see this drop off in 2020 and into 2021 of ED visits due to COVID. But when we look at these trends, and what we look at over time is you see some variation across the specific rates, but over all these years, this trend that we see is this constant gap, this clustering with the rates of ED visits in green for Black non-Hispanic individuals and in blue for Hispanic individuals being consistently higher year after year as compared to the white non-Hispanic population shown in orange, and then the Pacific Islander populations shown in the darker blue color. So despite what we know in our state, which is that although we don't see significantly higher rates of asthma among Black and Hispanic populations, there are these huge inequities in terms of who bears the burden of worse asthma outcomes, which we see here in these utilization rates. So what is our asthma program in Massachusetts doing? How are we applying a racial equity lens? So again, as I mentioned, we're being intentional and explicit in the language we use. So here's our new mission statement that we've rolled out back in 2021. And I won't read it for time's sake, but you'll see here that we are naming inequities and we are naming the role that systemic and structural racism is playing. So just to highlight a few examples of how we're continuing to apply this lens. So in this first column here, we have thinking across many of the XALE acronyms. We created our most recent 5-year strategic plan, which we did in partnership with MAP, our statewide asthma coalition. And this was during COVID, so it was all virtual, but we did many partner engagement sessions with over 40 partners across the state to help understand where the greatest need was and where we collectively thought we could make the greatest impact. And so through this process, we utilized our Leading with Race and Racism framework to develop goals, strategies, and activities aimed at addressing the inequities we see here in Massachusetts. We also took a data-driven approach to think about how we can be most impactful with our limited resources. And so we identified 11 communities of focus, and these were the communities at the time that were bearing an inequitable burden of worse asthma outcomes. So looking not just at asthma rates in these communities, but asthma-related ED visits and hospitalizations, and other factors such as environmental justice designations. And then making a commitment ourselves at DPH in our program and among our partners to center these communities in our work. The second item I want to highlight here is our commitment to the CHW, or Community Health Worker-led Asthma Home Visiting Program. So thinking about the H in that Exhale acronym. So this is something that our asthma program has been really committed to for many years. And again, we are very fortunate here in Massachusetts. We have a really robust CHW workforce, a CHW certification program, and we, at our asthma program, get to work closely with our Office of Community Health Workers that also sits in our bureau at DPH. But our 9 has offered a free 4-day training for CHWs in Massachusetts who are conducting asthma home visits. And it is led by a really wonderful team of committed and experienced trainers, some of who are here today. And with the goal of supporting this amazing CHW workforce and honoring their lived experiences, their role in both the asthma care team and in a comprehensive asthma home visiting model, and of course, the amazing impact they have in the lives of patients and in their communities. And the third example that I want to highlight here is our Pediatric Asthma Data to Action project. And so this is thinking about part of that second E in the Exhale acronym, the environmental policies, and touching on several other components. And so this project is a collaboration across several DPH programs, including ourselves, the asthma program, the school health unit, the indoor air quality program, and the environmental epidemiology program. And so just this past school year, we piloted this proactive approach to reaching out to schools with the highest asthma burden. So thinking about not only, again, the rates of asthma, but the community level asthma related ED and hospitalization data and environmental justice designations to offer these schools free indoor air quality assessments by our IAQ program, and then follow-up TA materials and educational resources to help schools in making policy and systems changes to support healthy school environments, especially for students and staff with asthma. And so this is a shift from our previous work, where these IAQ assessments and some of the other TA that we were supplying from our program was really being provided upon request. And so, but the schools and districts requesting assistance weren't always the ones that we had identified as having the greatest burden. So again, it's this shift in approach. And so some of this work that I am talking about is not quite at the structural or the root cause level, thinking back to that health tree. But these are really examples of some of the intentional shifts in utilizing a racial equity lens and prioritizing higher burden communities that we've done in our work. Do we have some time to go through this? Okay. So on your tables, we have passed out some of these materials. But I'm just going to really quickly walk through this racial equity reframing tool that we like to use. So we've used this over the years in our asthma program, our bureau, and across the department. And this really is an exercise in challenging the traditional public health approach that we have all been taught. And I want to name that this is not meant to be a critique of any of the previous work from the department or from anyone else's program, but it's a tool that can be used to help us think through a racial equity lens. This is something that can be done at the program level, the intervention level. We often do this with partners. It really helps to highlight some of the assumptions that are being made and definitely sparks some very interesting conversations. So you should all have that handout on on your tables, there's one copy that has like the directions and a filled out grid, and then there should be some copies of the blank grid as well. So as the directions say, the racial equity reframing tool uses 5 questions or framing elements and is intended to guide discussions across a variety of partners and topics. There is no correct outcome of this exercise, and the solutions that get identified as a result often depend on the granularity of the identified problem, the range of partners that are involved. You could do this twice with the same people and get different outcomes. We often first do this exercise with a if money and political will were not a consideration caveat, what would we do? Which can be a great way to start thinking creatively. So again, this exercise often exposes unspoken, pervasive assumptions that underlie how we think about our work. By surfacing these assumptions and making them explicit, you can question whether they are helping to address inequities or if they might in fact be reinforcing inequities. So as you'll see, there is the 5 framing elements, and then there's the traditional approach and the racial equity approach. I'm just very quickly at a high level, I'm going to walk through an example. Thinking about the traditional approach is where we will start. So when we say, what is the problem? Traditionally, we talk about non-compliance with asthma medications as a problem. If we were going to do this for the traditional lens again, what's the cause? We might say, or we're taught that this is due to patients or parents just not following the prescribed medication regimen, right? Not taking their controller medications. What's the solution? Again, traditionally, we say we need to educate patients and families on the importance of medication adherence. What action is needed? So again, we're saying we need to educate the patients and families. And then what values are being highlighted? So we're really thinking here about individual responsibility. We're really putting that blame or that onus on the individual or the family for not adhering to the prescribed medications. So this is an oversimplification, of course, but it is pretty aligned with some of the public health, programming that we've all done. So then we think about it with the racial equity approach. So here's the reframe, as we call it. So here we're looking at the problem. And if you look at the handout, the prompt there is to think about where's the injustice? What inequities are we seeing? So the reframed answer to that question could be, the problem is that inequities exist that make controlling asthma harder for individuals and communities of color. And then what is the cause? So here, if we're using this racial equity approach, we could say structural racism. It's creating inequitable barriers for controlling asthma, right? Thinking back to those social determinants of health. So there's inequitable access to culturally and linguistically appropriate healthcare. Or maybe the healthcare isn't being delivered in a patient or family's primary language. Or it isn't taking into account cultural norms around medication use. Or as we heard earlier, there are barriers to being able to afford medications. So then we think, what is the solution? So again, looking through this racial equity lens, we could say investment in communities of color, right? Addressing these social determinants of health. And this is at a higher upstream level, but thinking more about our education system, employment opportunities, policies that promote equitable distribution of wealth. We could think about culturally and linguistically appropriate healthcare. So, right, this is shifting the onus to the healthcare system on how we deliver care and away from the individual. And then we think, what action is needed? So again, in this racial equity lens, we could say policies and systems of investment in communities of color, culturally and linguistically appropriate healthcare systems. So, right, we're shifting the onus to the healthcare system or the medical schools to provide this training. Meaningful engagement with communities of color, right? So hearing from the individuals that are most affected, what they think the solutions are or where their priorities lie. And then when we look at the last framing question here of what values are highlighted, so before, right, we saw this individual responsibility, and what we're highlighting here is equity, justice, fairness, and shared responsibility. So again, this is an exercise. There is no right answer here. You can do this, like I said, multiple times and come up with a variety of answers. But I always find this to be a really interesting way to challenge myself and challenge that traditional approach that we were all taught and that so much of our public health work is framed around, and to really check my biases and push myself in my thinking. So we have about 4 minutes left, 5 minutes left. So I know people are eating lunch, and I know that there are folks that are attending virtually. So if people want to take a few minutes to just look at the reframing tool at your tables and chat with each other, and then maybe we can come back together and we can say either like what came up for you when you were doing this exercise, or you're looking at the exercise, or maybe if you even want to practice with that first, what is the problem?
Awesome. So I have 12:06. Let's take 2 minutes, and then we'll do a quick 1-minute report out for a couple of groups, and then have a few time for 2 questions or so.
Perfect.
For Michelle.
Thank you.
I'm not going to make you speak. I just wanted to say hello. Doing well. Looking forward to you. You'll be up soon. Finishing this, then we've got a patient testimonial. So excited for yours. As a fan. Yes, absolutely. Mary White is going next. Yes. Right there. Oh, you don't? No. I talked to her on the phone. I was like, she's about to go in 3 minutes. Just do it in person. Awesome, thank you. That's okay. Mary Wyatt, want to introduce you? Okay, so we're at the 2-minute mark.
Okay. Perfect. Thank you.
Want to get some call on a group, maybe? What do
Sure.
you think?
Is there anyone? Can everyone hear me? Is there anyone in the room that would like to share what came up for them at their table? Or I can call on my colleagues that I know are here.
I caught you too late. Someone at this table. Anyone?
Hi, everyone. I think important points that came up at our table were, one, having diversity of your workforce, because it allows cultural competency, it allows the language barrier to really be broken. The other thing that was brought up very nicely at our table was we have to keep in mind educational levels of a lot of our parents that come into, as we're trying to explain asthma or even inhaler technique, because some of them have had a 2nd, 3rd grade, or even a 7th grade education. So making it as simple as possible, and maybe having like figures, like cartoon depictions, because I think that's going to be important in breaking down more of the educational barriers.
I love that. I love that. Thank you.
Thank you. Great job. Who's next?
Anyone else? Oh, over there.
Hello, my name is Jonelle Johnson. I'm a registered nurse and a school nurse. And one of the things that I find is so important for helping parents to be consistent with medication is the teaching that the nurse does at the end of the visit while they're in the clinic. And really giving the nurse the time to teach the parents and let them practice. And when I was in practice in the hospital, my pulmonologist would shop at Oriental Trading, and each time kids came in, they could get gifts for coming, they could get gifts for showing that they did well with the PFTs, they could get gifts when they understood how to take their medicines, and when they had their next appointment and they knew that they were coming back in 3 or 4 months, they wanted to come back because they were going to be rewarded again. So it was very, very basic of getting to the parent and the child to work together with understanding how to use the medicine. Then another question came up at this table is what about the cockroaches and the poor living conditions that people were in? How do you handle that? And that was what, in Boston, we would refer them to we would make a referral to the city of Boston to Healthy Homes. And have people go into the homes. And at one point, they were even giving away vacuum cleaners to the families that they went to visit to help them to learn how to keep the dust up better.
Yep. Yeah, great points. Thank you. I don't know if there were any comments in the chat from online. I don't know if we can see that. No. Okay. All right. Does anybody have any questions?
A question that came up amongst a group of us who are chatting is that some states do not have an asthma control program as part of their Department of Health and Human Services or their health department. What is your recommendation about what clinicians and advocates and researchers can do to fill in that gap? And two-part question, perhaps get a program in place.
Yeah. Yeah, I mean, funding is always an issue, right? Thinking about how we can fund these programs. And yes, the CDC actually does not fund all states in the U.S. for their asthma programs. I think there's only 29 states that are funded, which is definitely challenging. I would say that there are a lot of organizations at the national level, right, like the Asthma and Allergy Network, that have a lot of materials and resources and trainings that can be made available, that can be used in other states. And, you know, one of those things that came out of COVID is so much of it is virtual now, so it can be more accessible to folks. I think the on-the-ground funding of this work can be really challenging. It's expensive, and when you don't have when you have those little funding streams where you set up a program and then it disappears, that can be really challenging for folks. But I think there are resources that exist out there. There's organizations that are funded to provide TA to states. And I would say trying to, using tools like this where you're shifting your thinking and you're trying to think, is there a way that something that I'm already doing, I can slightly reframe that to think about, what best serves my community. But yeah, the funding challenges are real.
Thank you. Any other questions for Michelle?
It's not really a question, it's more of a statement, I hope. Excuse me. My name is Sheila Brown, and I'm with the Environmental Protection Agency. And one of the programs that I work on or work with a great team of people is our asthma program. And our goal is to reduce in-home asthma triggers. And I just wanted to say and let everyone know that we recently stood up a page on our website that talks about the indoor environmental determinants of health, which is a subset of all the different things that I've heard today about social determinants of health. So please check it out when you get a chance. I did put the link in the online chat, and we have a lot of resources. Well, we have a plethora of resources on reducing in-home asthma triggers. So please check it out. Oh, and also please join our asthma community network.org, where you can interact with we have 5,000 members now. You can find our archived webinars, just a lot of great resources on that website. So thank you.
Thank you.
And we can get just another quick question in there if someone has one. Okay. No? Well, thank you, Michelle.
Thank you.